just I would like to say that laparoscopy is not a reference way of access of stone treatment, of course, because you have each kind of endoscopic approach which are more simple. But sometimes, in some very big stones in iliac and lumbar ureter, it is possible to access with a direct laparoscopic approach, extra or transperitoneal way. And if you have a very large stone with obstruction of pelvis, with a very large size of pelvis and obstruction, it will be for us more easy to perform. That we performed many years before with open surgery. We can perform now very simply with laparoscopic approach. So I would like to show you a small movie with many aspects interesting for the course. On peut mettre right pyeloplastie. So it will be the pyélotomie, pardon. Je peux voir le titre non, je n'ai pas lu. Oui, le pyélotomie, c'est bon, d'accord, merci. So in this case, it was a lady with a strong pain and fever with infectious consequence of the very large stone in pelvic junction with obstruction. And because of the size of the stone, because of the extrasinusal development of the pelvis, we decide to perform a laparoscopic approach. So we start in the same way. I said that you have a liver, you have the duodenum, which is here, you have just to incise and to divide the peritoneal covering part of the lower part of the kidney, and it will be exactly the same approach that we did for the pyeloplasty. So I'm going to advance a little bit more, and I said that what we have to find is the ureter. So psoas muscle is here, and here we have a nice structure, which is the right one. Just like to go back a little bit more. So we approach the psoas muscle, and following the psoas muscle, we find a wide structure, which is this one, and in my, I said, oh, very nice, we have ureter immediately. So it was too easy to be honest. And in fact, this wide structure is not moving, so it's not exactly aspect of the ureter. And in fact, it was one of the parts of genital pellicule. And this genital pellicule, you can observe, was a plexiform one with three small parts of genital vein going and joining the right aspect of vena cava, which is here. You see it? And so it's normal because it is impossible to find immediately the ureter when you approach the psoas muscle, which is way. That means that we have to go more deeply, and of course, ureter will be behind the limit of genital vein and in contact with vena cava. So we have to follow the limit of vena cava. And don't be afraid because it is very safe, the section, if you respect the good space. And you can note that ureter is here and vena cava is here. But anyway, it's not a problem. You will be able to find the good space between vena cava and the ureter itself. And so it will be possible to perform a complete dissection of the ureter and to follow its road to join the pelvis. And at this place, you understand that your genital vein is going to cross the road of the ureter to go in a contact with the right side of vena cava, and the ureter is going to move posteriorly behind the limit of genital vein to join the pelvis. And you can note that at this place, you have any inflammatory reactions because of the presence of the stone, and so you can perform quite a simple and safe dissection between ureter and genital vein. So vein is led down to the lower part of the field, and the ureter that you observe here is going to take a different axe of the road and to move the pelvis. So this first part of the movie is interesting because of a specific aspect of this genital vein, which can induce mistaking in identification of the laparoscopic landmarks. So we move to the kidney because the job is to approach the pelvis, and progressively you are going to note that the aspect is going to change, because if you perform a laparoscopic approach of the kidney for stone disease, of course you will have to deal with a very strong inflammatory reaction, and don't be afraid, it's just because of the stone, but you know this aspect because it's the same one that you can find in endoscopic or surgical approach. So we move, and what is very important is to be sure of the identification of the ureter, because at the end you will approach the pelvis of the kidney, and it will be more difficult to be sure that this structure is the pelvis and not the vein. And so we approach, we can discover now the classical aspect of the pelvis, which is modified because of the stone. Of course, the section will be more strong. You have to push, you have to divide to enlarge your surface of access of the pelvis. It is bleeding, of course, because you have a strong inflammatory reactions, and you are very safe because if you have some doubts, you have just to go back and to move the ureter to be sure that this structure is the pelvis, and you will be able to divide it later. Because sometimes it's so inflammatory that you can have some doubts between the pelvis and the vein. So at this time, we have certitude that this structure is the pelvis. So we are going to divide the pelvis, so you can use different kinds of instruments. You have laparoscopic scalpels that you can use, but here I use the laparoscopic scissors. I perform a first horizontal division, and then to enlarge access of the pelvis, I use a vertical division of the pelvis to discover the stone. So once again, you can observe the importance of the job of the assistant, which is giving you a good exposure and accessing with a suction device to the pelvis. So you discover the stone, and you are going to remove the stone, and you have to be very carefully, because it's mandatory to avoid a breaking of the stone, because one of the advantages of laparoscopic approach is to perform treatment of the stone in one shot. That means that you have to avoid any breaking of the stone. So, if necessary, if you have some doubts, you can introduce a flexible endoscope in the pelvis if you want to check if you have no remaining stones, and then the job will be the same. You push your guide, and you push the double G, and you perform just laparoscopic suture of the pelvic division. So just to say that sometimes laparoscopic approach can be a very safe and simple and efficient way of access of big pelvic stones. But it is not a reference treatment, of course. Okay, so I think that everything has been said. We have some comments or questions before the break.
State after ureteral lithotomy.
Sorry?
After ureteral lithotomy, stone in ureter.
Vertical incision of the ureter, vertical, the lens axe. You remove with a laparoscopic wasper.
Passing a stent will be difficult, suppose it is in the mid-ureter.
Yes, it's very good. Sometimes you can place before the double stent, and so you have your job with the double stent in place. And sometimes it's not possible. You place the first part of with the same technique that Christian described, the first part of the lower part of the double G vertebral which is pushed with a guide, and and then
upper part only pass. There is no guide wire for the upper part.
yes, you have some multi-perforate double stent with a long part of the stent with some holes, and you can introduce by this part. But if you are just in the middle part, it's difficult, and some guys didn't place any drainage because at time of open surgery it was used to perform incision, extraction, suture, and extra peritoneization of the ureter without drainage. So, but you're right. But sometimes you can deal with both part of the budget.
What would you refer this laparoscopic approach and the limits for the vertical approach for the patient?
Yes, but I do not prefer because I repeat that referent options of treatment are endoscopic and percutaneous. But I said that in our hands, I think that laparoscopic approach is less dangerous about risk of accident than the percutaneous approach. You have no risk of bleeding, you have no risk of, and in situation of urinary infections because of the obstruction and because of stone, perhaps you can reduce the risk of infection accident. But I am, I go back in this talking. I'm going to let Christian, which is referring to the stone treatment, because it's not a recommendation, just one of the options that you can propose.
In all the international recommendation, it is an option, the laparoscopic approach, but it depends of the equipment, it depends of the case, it can be discussed, but it's not a mandatory procedure.
Yeah, of course, it's one option.
But you need to train, you need to be confident with suturing.
But in this kind of course, I want that we can present some laparoscopic possibilities of usual situation. And it's quite simple. It's okay? A small break, 30 minutes, and we wait for you for the following part of the course. Thank you very much.